Bismillahirrahmanirrahim. So we can start now. Topic for today is management of major bleeding, especially in the context of trauma. The need for this has arisen uh, as we have now been becoming more and more busy and doing complex surgeries. There have been patients around uh, who have needed blood and blood products, and we have realized that because of the lack of clear guidelines and procedures, sometimes these patients are not managed as we would like them to be. So I have discussed this with our hematologist, Dr. Yasir, and Dr. Shagul as well. This is a protocol which we are presenting as a guideline. This is a proposal only, and we would welcome all suggestions. And once we have the input from all of you, we will implement this. This protocol or guideline is based on European guidelines, so obviously there may be some discrepancy from the guidelines elsewhere, but we are open to it and we have to adopt it according to our own situations. So let's start with some cases where we can see that so this is I'll start with a few cases which all of us will come across, and then we discuss the management of these things. So the first one is a 60 years old female inpatient on aspirin, catches her leg on a wheelchair in an X-ray and has severe bleeding from varicose veins. Many of us has come across this. Second case is a 55-year-old male with massive upper GI bleed and history of severe liver disease with esophageal varices. So you can imagine if that person starts to bleed, already compromised liver and then esophageal varices. So where are we going to stop and how are we going to manage this? The third one is a relatively new issue with the Novavax of the dogs. 65-year-old female on dapigatran for atrial fibrillation, falls from bed. She's very tender all along the left side, elbow, chest, and abdomen. She's tachycardic and hypotensive. So obviously we can feel that this lady is losing blood, and we have to do something to arrest further bleeding and stop her from deteriorating. So we start with actually defining what is major or critical bleed. And the loss of 50% of the blood volume in 3 hours, or blood loss of more than 150 ml per minute, a replacement of one whole blood volume, or transfusion of 10 red cells concentrate in 24 hours. So there are a number of definitions. We can apply any of these, and there may be some more, but the majority of the accepted definitions are these four. So any of these patients who has any of these conditions will fall into the major critical bleed. The background is that uncontrolled post-traumatic bleeding is still the leading cause of potentially preventable deaths among injured patients. It's very important to remember that 1/3 of all bleeding trauma patients show signs of coagulopathy at hospital admission. And these patients develop multiple organ failure and experience death more frequently than patients with similar injury patterns in the absence of coagulopathy. The early acute coagulopathy is associated with traumatic injury, and it's recently been recognized as a multifactorial primary condition that results from a combination of bleeding-induced shock, tissue injury-related thrombomodulin upregulation, thrombin, thrombomodulin complex generation, and the activation of anticoagulant and fibrinolytic pathways. So it just reminds some physiology for our traumatic coagulopathy. In patient who has pre-existing factors like genetics, hemophilics, protein C, S deficiencies, other factor deficiencies with medical illnesses, diabetes, liver disease, or any medications like uh, vitamin K dependent, warfarin, heparin, or Dovex. Whenever they suffer trauma, the three uh, cascades or three events are triggered. The first one is the loss of hemostasis factors due to hemorrhage. And at the same time, an inflammation is there and there is activation of the fibrinolysis. Now, the hemorrhage in itself also activates the fibrinolysis and that induces traumatic coagulopathy. Whereas loss of blood leads to shock, gives rise to tissue hypoxia, and that contributes to acidosis, which increases the traumatic coagulopathy. Now, when we try to resuscitate these patients, we give crystalloids and colloids and give RBCs. That leads to dilutional coagulopathy and exacerbating the traumatic coagulopathy. So this is a cascade which is triggered after a patient suffers hemorrhage and trauma. Management of bleeding and coagulopathy following major trauma and updated European guideline. This was first published in 2004 and since has been revised, and nowadays we are in the 5th edition. And today's talk is based on these guidelines. The key messages from this guidelines is that we need to measure and monitor and support coagulation initially and as early as possible, and should be used to guide a goal-directed treatment strategy. A damage control approach to surgical intervention should guide patient management. Coagulation support and thromboprophylactic strategies should consider trauma patients who have been pre-treated with anticoagulants or platelet inhibitors. Local adherence to a multidisciplinary evidence-based treatment protocol should serve as the basis of patient management and undergo regular quality assessment. And they come up with some recommendations. They recommended that each institution should implement an evidence-based treatment algorithm for the bleeding trauma patients. They also recommend that treatment checklists should be used to guide clinical management and that each institution should include an assessment of adherence to the institutional algorithm in routine quality management. So we intend to do all these three in Maruf Hospital, and the talk today is based on this. This is the algorithm, the guidelines which we are proposing in Maruf, and it basically has 6 components, which are all enumerated in this flow sheet, which will be circulated once we accept on these guidelines. But the major components of this guideline is the first thing is the resuscitation, then second is the identification of the source of bleeding, third is the rapid control of bleeding, fourth is perfusion, oxygenation, fluid, and temperature, blood products, and coagulopathies, and then stand down. We will discuss each one of these 6 components in a bit of detail. As regards to resuscitation, as soon as a patient we suspect that has major bleeding, the definition we have already mentioned at the start, we should notify the senior radiation surgeon, anesthetist, and consider radiology and ortho hands pre-alert. We should put the blood transfusion blood bank on standby using the extension 1076. We should insert 2 large bore IV cannula, 14 gauge or 16 gauge. If we can't do that, we can consider intraosseous or central lines. I should take the venous blood gas or arterial blood gas as may be possible from the ER. We should do a lactate, blood gases, ionized calcium, a full blood count, INR, APTT, and fibrinogen. these are the initial investigations should be sent from the emergency. We should group and cross-match in an emergency. If you don't know the patient, we would use one unique patient identifier, the temporary ID and on the electronic band, and gender should be used. We should think about inserting an arterial line and consider tranexamic acid 1 gram over 10 minutes and then 1 gram over 8 hours as early as possible. In an emergency, what I said was that if you don't know the patient's name, so there will be one unique patient identifier, which would be the temporary ID, and the gender can be used as a surname. Tranexamic acid has been proven in the patients of trauma, and we all know about CRASH 1 and CRASH 2 studies. And it clearly showed benefit, not only benefit, but it did imply that tranexamic acid given within 1 hour of arrival of the patient reduces the relative risk to 0.64, and then if it is delayed for more than 3 hours, it increases to 1.44. So it actually inhibits the fibrinolysis, which, if you recall, as we saw in the second slide, that fibrinolysis is triggered once there is trauma. So basically, it helps in the inhibition of the fibrinolysis. Second part of our protocol is the identification of the source of bleeding. So you should look on the floor and for more. So if there is an external bleeding, we know we can stop that. But the other 4 places where we should look for is the chest, abdomen, pelvis, and the long bones. The modalities used to check the source of bleeding: external, we can see chest, bones. We can do a fast scan. Hematuria, we need to find out what the catheter, and if we suspect a pelvis injury, we obviously should insert a pelvic binder. We need to quantify the volume of blood loss. Visual and ATLS classifications we can use. We'll see in the next slides. Bleeding sites, as we mentioned, there are external and 4 more. If we have external bleeding, we'll obviously see and can ask the paramedics or the people who brought the patient, was there any bleeding at the scene as well, or did it bled during the transfer. The chest, we need to do CT. If we suspect an aortic dissection, CT, aortoangiogram. If we do the cardiac, if we suspect cardiac tamponade, we have to do the bedside. In unstable patients, we can't take them for CT, but fast scan and early laparotomy is the answer. But if the patient is stable and there is clinical concern, then CT abdomen should be done. As I mentioned, for the X-ray, if we suspect pelvic injury, you should do an X-ray and apply pelvic binder. Even if you cannot do the X-ray, you should still apply the pelvic binder. I think this is all we have gone through. It's just an arbitrary classification of the shock. In essence, it doesn't demark itself. But if you feel that we say that we can divide shock into 4 classes, then anything when you use 1500 to 2000, 2000, 2000 ml of blood, you're actually in the class 3 shock, and that's the time when you decrease blood pressure and decrease blood pressure. Yeah, sorry for this noise. I think they're starting to work outside. We'll ask them to stop. This is the same, again, classification from the Advanced Trauma Life Support course, which says that how do you say that a patient has bleeding or not? Once they present to you, you give them fluids, crystallize initially, and if they respond, but after some time, if they reduce the blood pressure again and they drop the blood pressure, then they are transient responders. And these are the patients you should be very cautious with and alert yourself that these are the patients who are actually bleeding. So the next step in the algorithm is the control of bleeding. So that obviously you need to turn off the tap wherever it is coming from. We said if it's external, we apply external pressures and bandages. If it is from the four cavities, we have to do accordingly whatever and wherever the patient is bleeding. If it is in the chest, we need to think about the thoracotomy, and obviously there are guidelines for that. If you do the chest drain and it has more than 1.5 liters, and then it has 200 ml per hour for thoracotomy. Aortic stenting requires senior surgical opinion. Abdomen, if you have to go and patient is unstable, you need to do the backing, direct control, and hemostatic instruments. Sometimes if you have to space with extenuation, you need to call upon Jamarda P and ask to cross climb the aorta for us. Pelvis, as I mentioned, even in our trauma patient, we should apply pelvic binder and avoid repeated examination of the pelvis ring. If the patient is, if pelvic bleed is severe, then you need to think about pre-peritoneal packing and direct surgical control. And if you have the intervention radiology on board, you can obviously think about angiography and embolization. Long bones, we all must splint and put slabs on because that actually helps in hemostasis and decreases the further blood loss. This is a pelvis fracture, basically implies that this patient has pelvic bleeding, and if you can't do anything, at least we can apply a white sheet or a pelvic binder to help stop this. Pelvic fractures, as I mentioned, we need to sometimes do angiography and embolization for effective arterial control. Damage control surgery is a concept where you actually try not to do heroics, but try and do the minimum possible and come out. These patients, multiple trauma patients who need to go to theater, say they have a perforated bowel. So we're not going to stay there and try and repair that bowel. We can apply to staplers, take away that part of the bowel which is perforated or needs a lot of time to repair, then pack that patient. Say if there's liver trauma, laceration, we pack that and come out. And we have seen here a couple of patients where Dr. Faisal and his team did actually do the damage control, the back to the patient. And even recently, I think there was a patient with a ruptured placenta where patient was packed at 3 times, and then on the 4th or 5th day, patient was then actually there was some repair done on that patient. So that's the concept of damage control, that you do minimum surgery, then patients are admitted in ICU, they are resuscitated. We need to focus on the temperature, correct the acidosis and coagulopathy, and then later on, definite surgical repair. Damage control surgery is indicated in severely injured patients, where ongoing hemorrhagic shock and coagulopathy, along with their hypothermic, acidotic, and the surgery takes time. So then at that stage, you don't need to spend that amount of time into the definitive surgery. The fourth part of our algorithm is the perfusion, oxygenation, fluids, and temperature. And as we all know, hypothermia worsens the coagulopathy and increases bleeding. If the patient doesn't have brain injury, we should aim for a systolic blood pressure of 80 to 100. The concept of pervasive or low volume resuscitation is gaining weight in traumatic patients, where we no longer aim for a normal blood pressure, as to speak. But if a patient has traumatic brain injury, we should aim for the normal blood pressure and avoid hypotension in such cases. Crystalloid is the initial resuscitation fluid. There is possible role of hypertonic solutions as well, which is still under, I would say, the genes out on them. And obviously, we say we need to maintain normothermia and prevent heat loss. We should warm the resuscitation fluids and blood before transfusing to the patient. The most important part of today is the blood products and the coagulopathies, which you need to have ready. And I've discussed with Dr. Shahgul, and we are planning to have 3 packs available in the blood bank. The first pack would be 2 units of O negative. So you need to call the lab and request the emergency transfusion packs. The first pack would be 2 units of O negative blood. The second would be 4 units of red cells, cross-matched or type-specific or O negative, 2 grams of fibrinogen, which is given as 2 bags of cryoprecipitate. Platelets, 1 pool if localized bleed, 2 pool if traumatic brain injury or multi-trauma. And 1 pool is actually a mega unit, which is equal to about 5 to 6 units. So in that bag, you will have about 10 units of platelets. The pack 3 is directed to the target levels in step 5, which we will just discuss. It's important to remember that you can give O-positive red cells for all men and women above 60 years. Now, how do we reverse coagulopathy? We need to ensure that we have sufficient platelets, fibrin, and clotting factors to form a clot, and we minimize the clot breakdown. So to achieve the first aim, we obviously said to allow clotting, we give the pack 1, pack 2, pack 3 as may be needed. And then we should, to prevent the clot breakdown, we should use tranexamic acid, which is a lysine analog and a competitive inhibitor of plasminogen. Recombinant factor 7A has limited role in surgical bleeding. Once we have achieved the desired results and we have patient shifted down to the ICU and we no more require the emergency packs, we will need to call the blood bank and inform them that now we're standing down the emergency and patient's now in ICU. At that stage, we need to make sure that the patient has the correct name band with updated patient identifiers. We should need to send a new title screen sample to the lab with the updated identifiers, and this sample will be used for the future blood products. If you remember from the start that there was a case at the start of the session where we said the patient is on anticoagulants, one of them is on warfarin, the other one on tapicabtrin. So this will be part of this algorithm will be part of the guidelines, which actually tells you that if you need to reverse what we need to do. So if the patient is on unfractioned heparin, we all know the half-life is about 45 to 90 minutes. The blood test we need to do is APTT, and the antidote is protamine 1 milligram per 100 ml units of heparin, maximum 50 milligrams. If it is a low molecular weight heparin, the half-life is 4 hours, and we need to get a blood test, you need to anti-10 is only if within 8 hours of drug, protamine 1 milligram per 100 ml units, followed by 0.5 milligram per 100 ml units. All these will be part of the protocol. Warfarin, we all know, check with INR, the half-life is 20 to 60 hours, and you need to give either PCC, prothrombin complex concentrate, which is not available in Pakistan, you need to give 5 milligram of IV vitamin K. You can think about fresh frozen plasma. Novax and Tovax, I'm going to talk about in the next slide. Aspirin, 5 to 7 days half-life, and if you need to reverse that, you need to do 2 units of platelets. Clopidogrel, also 5 to 7 days of half-life, and you need to give 2 pools of platelets. The rest all are mentioned here, and we will have this as part of the protocol. Coming to the last slide, this is the management of major bleeding with factor 10A inhibitors and direct thrombin inhibitors. We all know that oral anticoagulants actually work in 2 ways. Few of them are factor 10A inhibitors, and the others are direct thrombin inhibitors. Factor 10A inhibitors are generic names rivaroxaban, apixaban, and edoxaban, which is Xarelto, Eliquis, and Lixiana. Direct thrombin inhibitors are dabigatran, Pradaxa, and argatroban. These are the direct thrombin inhibitors. So what do we do with patients with NOVAX presents with trauma or with major bleeding? So we need to stop, first of all, stop the medicine. Then it's long. Also, we need to stop the antiplatelet agents and stop antithrombotics. Example, heparin, low molecular heparins. We need to remember one thing, that a patient with polytrauma who's bleeding has to have mechanical anticoagulation devices in the ICU, and we need to be, and they should start within 24 hours of the patient arriving there. But then specific investigations we need to do for these patients is PTA, PTT, and thrombin time. It's only needed for patients who are on direct thrombin inhibitors like dabigatran. Obviously, you need to check for footpad count and renal profile. If their PT is normal, you need to just do standard resuscitation and transfusion names. If the PT is prolonged, and we say it's a minor bleed, you can use mechanical compression, elevation. We need to think about tranexamic acid. If it's a major bleed, then we need to give tranexamic acid 1 gram TDS IV, and we need to ask hematologists to give their input as well. In terms of life-threatening bleed, again, we need to ask the hematologist. But we need to think about fresh frozen plasma, PCC, along with direct thrombin inhibitor, which probably is not available in Pakistan. So a major bleed is a symptomatic bleed in a critical area or organ, like intracranial, intraspinal, intraocular, retroperitoneal. A drop in hemoglobin of more than 2 grams of where more than 2 red cells are required from a preceding hemoglobin should alert you to this. So this is in a nutshell the algorithm which we are hoping to have implemented in the hospital. I thank you all for listening, and now we can discuss. If there are any questions, I'm happy to take them. Thank you.
Dr. Waheed, thank you very much for such an instructive and detailed presentation of acute management of bleeding. I just had a question about one of the slides that you had about standby or stand out. Can you go back to that and explain a little bit more?
Yeah, it's actually, Shagul, when we start, when we are in the emergency, say, we will call the blood bank and say that now you need to, it is basically an alert for the blood bank that
okay.
Transfusion, okay? And then the down is basically to tell the blood bank that now that emergency is over, now you can go back to your work, which is your normal routine work. That's actually the stand up.
Okay. One more thing I wanted to add, the extension for blood bank is 1076 and 1075, both of them.
Okay. I think I checked with yesterday. They said 1067. Probably we need to change that. Yeah. Thank you, Charu. This is very
All right.
important.
Okay, thank you.
Thank you.
I have a question, but it's not related to the topic. You've done very well presented, very informative. Whenever we ask the patient to have a blood transfusion, isn't it usually the family who organizes it, or has something changed?
Actually, I think you see, this question has risen multiple times. The protocol we follow here, and which Shagul is always complaining about, is that the patients or their relatives do not donate blood. We do try and provide the blood, but as you all know, that the blood is not available, so we cannot buy it. So it's all that we have some MOUs signed out with other hospitals where we ask them to borrow the blood and for the acute emergencies. But we all encourage, and we have tried this many times, that any patient who's for the elective surgery must have a donor before the blood bank will issue that blood. And by and large, we do. In terms of emergency, no, we cannot ask them. So these packs, which is pack 1, pack 2, and pack 3, will be available as an emergency without asking donors. So I hope this is clear.
I would like to add into this a comment that it should be educated to the family that although we are giving you this blood for acute emergency or such and such amount of packs were used, but you have to in return send your donors, even if it is the evening or the next day, replace that amount of blood, not the same blood group, I mean any blood group, but blood bank will give you. You have to bring your attendants and send the blood in return. This is the policy everywhere. Unfortunately, sometimes the patient's attendants, they don't come back. So that's when we have a problem. We go in the negative balance. But we try to arrange ahead of time. But we need support because we need the families to be educated that they have to give us blood. And the clinician is only the person who can actually teach them and educate them that you have to bring the blood.
Especially, Shagul, after we implement this protocol, we would have to have at least 2 units of O negative present all the time, along with 4 units.
Yeah. Yes.
So the cooperation from the physicians is very important, and I think we need to go up and also look for some blood camps and things like that. So this would be, I think, a collective effort from all sides.
Exactly. So
I welcome you all, and I suppose there is no more questions. So we would welcome any further input into this. I would also circulate these to the surgical side and to the ICU blood bank as well for any further comments. And we hope to have these implemented in the next few weeks. Thank you.